Good afternoon, and welcome to today's webinar titled Family Crisis Response. This workshop is intended for relatives of adults with mental health and/or behavioral challenges. Dr. Esleru will overview strategies to better understand crisis situations and respond to keep everyone safe. The presenter will also identify resources, including the effective use of emergency services. While acknowledging the need for education around specific topics, such as today's presentation, the Family Support Center of New Jersey also recognizes that families have specific questions around their child's transition years. The Transition Matters website assists families and professionals in identifying resources to successfully transition your child or student with special needs to adulthood. Resources such as webinars, in-person workshops, and statewide and regional contact information are made available on this site. We encourage you to explore the site further and register for any upcoming sessions. Before we begin, let's take a moment to go over how you can participate during today's web event. Everyone has their own control panel in the upper right corner of their screen that looks similar to the one here. Use the orange arrow to open or hide your control panel. To listen to the webinar, you have two audio options to choose from: mic and speakers, and telephone. If you can't hear well using your computer speakers, you can elect to use your telephone to listen to today's session. In order to maintain the best sound quality possible, all but the presenter will be muted throughout the webinar. If you have questions or comments, you can submit them using the questions panel. All questions will be collected and answered at the end of the webinar as long as time allows. At this time, I would like to introduce this afternoon's presenter, Dr. Esleru. Dr. Esleru is a New Jersey and Pennsylvania licensed psychologist and certified clinical neuropsychologist who maintains a part-time private practice in Hamilton, New Jersey. She is a clinical administrator of the SCAT and ESCO programs of Trinitas Regional Medical Center. Dr. Esleru has over 20 years experience in working with individuals on the spectrum and their families. She is a certified clinician through the National Association for Dual Diagnosis. Dr. Esleru, welcome.
Welcome. Yes, thank you.
I'm just going to pull up your PowerPoint at this time, and I do apologize to everyone. We are at different locations, and we just need to make sure that our PowerPoint is working. Dr. Esleru, can you see the PowerPoint?
I most certainly can. Thank you so much.
Wonderful.
All right, so we can advance to the first slide. Thank you. So good afternoon, everybody. I want to thank Melanie McGackin for the invitation to talk to you about a very important issue, and that is behavioral and mental health crises. And particularly, I want to focus on the family, and that is we tend to focus on the individual in crisis. However, crises really affect all members of the family. So the purpose of the presentation is to point out some things that we might be able to do to avert crises, if crises occur, to better manage them, and to plan or learn from the crisis situation so that we can lessen the likelihood in the future of another emergency. So the purpose of the presentation is to take the focus slightly off the individual and see the person within his or her context of the family and broaden our understanding of how crises affect everybody. Family members need to be concerned at this time, if you are in crisis or you have a relative in crisis, with self-care as well as care of all the members of the family unit. So we can advance to the next, Melanie. Okay, we can advance to the next slide. Good. So what is a crisis? Crisis is when a person acts in ways that are negatively or even dangerously a dramatic departure from their usual and characteristic behavior. So most of you have a relative that has a behavioral mental health disorder. You have certain ways you characteristically respond and support the individual. But when there are changes in thinking, mood, and behavior that interfere with your relative's ability to pursue a normal routine at school, at work, within the family, or pursue relationships, then everybody is destabilized, and we have to do something different than we normally do. A crisis can be associated with the individual in crisis being very distressed, as well as members of the family being very distressed. And again, the whole family unit is destabilized. Everybody who's involved in the care and support of the relative is destabilized. And the person in crisis may display aggressive behaviors in the form of hitting, kicking, punching, etc., self-injurious behaviors, head banging, biting, etc., property destruction, and be verbally menacing or elope. That's not a definitive list of behaviors, but the most common things that we see when we see individuals present in crisis. So the person in crisis may be out of control, and they may feel physically and psychologically unsafe. And those are two areas we're going to be talking about a little bit more in a few minutes. Take it away, Melanie. So what are some proactive strategies that we might put in place even before somebody reaches the point of being in crisis, and hopefully may even avert a crisis situation? So one of the things you may do is you may have an area of the house in your living situation which is less stimulating for the person, and you might kind of engage in a timeout procedure at home that gives the individual a chance to calm down and regain composure. It may not be the person's bedroom, because sometimes the person's bedroom is very stimulating and there are a lot of items in the person's. It's best to be a place where there's not a lot of items that can be destroyed or can be stimulating for the individual. And not all behavioral outbursts require medication or hospitalization, and that's why we want to look at what we can do to avert the more serious crises that you may have confronted in the past with your relative. One of the things about many individuals that we work with in crisis is they've never really learned how to calm themselves down. So when they get upset about something at school, at work, in the community, they don't have strategies to learn how to kind of regain their composure. So the time to begin working on this is early on, to teach your relative breathing exercises, forms of self-distraction, and ways of reducing their anxiety. And I'm talking about non-pharmacological, not using medication or drugs, but coping skills that the individual can deliver or develop, so that if they're upset, they can use those skills. You can prompt them to use those skills, and it's associated with the individual becoming calmer and averting a crisis situation. Sometimes a simple change of environment, like going for a walk, taking a soothing bath, being distracted in another situation, taking a ride, that may be sufficient to just change the situation and help a person calm down. Or if the person's behaviors are annoying but not dangerous, you might be able to ignore the behavior and not give it any attention, thereby making it less likely that they'll engage in annoying behaviors in the future. Again, that would be for behaviors that are not dangerous. A mental health crisis. So although criteria for hospitalization is dangerousness to self or others, if we wait for an emergency room situation as being the only way of addressing mental health problems, then we're all going to be in a lot of trouble. That's much too narrow a focus in terms of addressing mental health issues. Let's not wait. Family and staff who are involved with your relative should not wait until it reaches the point where somebody's physical safety is threatened. And the emergency room is not a particularly good place to have as a portal for stabilization services. When you go to the emergency room, it's whether or not the person needs to be hospitalized, and this often does not become the entree to getting the kind of stabilization services the person may need. So we can avert crises if we pay attention to things earlier in the chain of events. So when your relative begins to express feelings of distress, or you observe they may be distressed, that's the time to begin finding what supports or interventions may be helpful in lessening the distress. If you notice your relative has changed in their characteristic functioning, that should be a red flag to at least look into what's going on, that your relative is not performing the same at school or at work or in community as they might have characteristically done. And if the family has gone through some catastrophic life events, or if the individual has been exposed to something, that is another time to really give a very careful look at what supports can be put in place. For instance, the death of a family member, the illness of a family member, if there had been a fire in the house or a theft in the house, some kind of event that would affect the person, maybe even the whole family, and we need to pay attention because the person may have a destabilizing response to the event. Okay, Melanie? Okay, so how do you assess the severity of a crisis? How do you know when things have reached a critical mass and it's time perhaps to take a trip to the emergency room or to do something that is beyond what you typically do in response? So we ask, has your family member lost control? Are you able to redirect the person so that they can follow your instruction and calm down? Is there a possibility at that moment in time that somebody could be hurt because of this person, your relative, being out of control? Is this person or others in immediate danger because your relative is out of control of his or her behavior? So what can you do to avert a crisis? Well, first thing is, if you've noticed the person is unstable, destabilized, has not quite reached the point that it's become dangerous, but things are not going well, you want to bring your relative to a physician or a practitioner for a comprehensive rule out of medical conditions that may contribute to thinking, mood, or behavioral problems. Maybe your relative has a urinary tract infection. Maybe your relative is in pain, and there are some medical issues that are driving what appears to be behavioral crisis. Then you want to stay in close communication with your relative's treating psychiatrist or practitioner who prescribes medication for mental health problems. The psychiatrist, advanced nurse practitioner, or the primary care physician who's prescribing medications should be among the first people who gets a call if there is a problem with your relative's behavior. I put on your screen two numbers for crisis response. The first number is the 888 toll-free number for SCAT, Statewide Clinical Consultation and Training. That is the program for which I am the clinical administrator. We will send a clinician out to do a face-to-face interview and assessment of individuals who are gearing up into a crisis situation. You don't have to wait till the person is in the emergency room. We see people in family homes and day programs and in the hospital if it is necessary that the person present to the emergency room. This is for adults 1 and older. For children who are would be through the Department of Children and Family Services. For crisis response, you would call Perform Care, and I put the Perform Care toll-free number up for you. You have the website for both SCAT and for Perform Care listed in your file. Again, this is for children through the age of 21. They are considered to be children until they reach age 21, and it is their crisis response that is called up. Next. So who's prone to crisis? Well, in fact of matter, any of us, if stressed beyond our capacity, could experience behavioral or mental health crises or destabilization. However, there's some individuals that are more likely to have crises. There are individuals who already have a history of significant mental health diagnosis, such as schizophrenia, schizoaffective disorder, bipolar disorder. In the population of individuals with intellectual and developmental disability, people can have severe OCD that also may lead to crisis situation. Individuals may have significant behavioral histories that are associated with developmental disability, such as self-injury, property destruction, impulsivity leading to elopement, and aggressive behaviors towards others. And individuals who have limited age-appropriate social and emotional coping skills because the person becomes overtaxed in a situation and then responds with some severe behaviors associated with crisis. Next, Melanie. So intervening in person-centered ways. Appropriate interventions are interventions in which we seek to understand the individual and his or her unique circumstances and personal preferences. It's not as though one size fits all in terms of crisis response. The intervention should involve a person as much as possible so the individual does not feel that something is being done to them, but rather that they are participating to the extent that they can. And the fact of the matter is a feeling of being out of control, which occurs during a crisis situation anyway, only further adds to distress if people feel that something is being done to them rather than their attempt to be engaged in some way. And the family should be involved in helping regain control. The crisis worker and whoever is involved in crisis response should actively partner with the individual and the family. Okay, Melanie. So during a period of destabilization, so when your relative is exhibiting signs of instability, they're unstable behaviorally or in terms of their mental health symptoms, you're going to enter into a period of watchful waiting. Keep your psychiatrists and helping professionals informed. This is not the time to withhold any information from crisis workers, treating psychiatrists, day program staff, or others. Everybody must be on the same page in terms of important information. So what might be important information? Well, medications may be important information for everybody to be aware of. Any events that may have occurred prior to the onset of the crisis behaviors, it's important for everybody to be informed of what happened immediately before. This is a time for everyone to have the same information in hand in order to have a coordinated response. You may want to reduce any task demands. If you see that the person is relatively unstable, not functioning the way that they usually do, maybe it's time to reduce the expectations on them regarding work, school, or at-home responsibilities. Make sure concerns have been addressed. Again, does the person have an untreated infection? Does the person have some other problem like pain, which may be contributing to their instability at this point in time? This is also not the time to change a medication regimen unless it's under the direction of a treating psychiatrist or other prescribing practitioner. I know that if things are going poorly, you might be tempted to kind of do something different with the medication. Medication should never be administered in a different way than prescribed unless the psychiatrist is working with you or the physician or practitioner working with you to change dosing and medication. Next. So I invite you, if you haven't already done so, to go on the SCAT website, and you'll see there is a tab for news and events. Look under that tab and you will find a PDF version of the Family Crisis Handbook. Family Crisis Handbook is a book that Donna Icavino, who's a family advocate, and I wrote in 2009. I think it was published with the help of the Division of Developmental Disabilities in 2009 or early 2010. And you will see that part of the book, it is a 55, no, it's more than 55 pages, but on pages 54 and 55, you will see there is a portable emergency plan. The portable emergency plan was actually meant to be on one page, double-sided on one page. So I invite you to remove that once you print it out and to actually copy it so it's both sides of one page. I suggest you laminate it and you have it accessible to you for future use. There you summarize all relevant information that you would have to bring or could bring with you to an emergency room to help crisis workers respond in the event that your relative goes to the emergency room. If you are your relative's guardian, your relative's legal guardian, then have legal papers available with you to bring to the emergency room, because you will be asked by a screener if you have those papers to establish guardianship, if there is something that you're going to be asked to consent to regarding the care of your relative. So please find those papers, get them somewhere where you have the portable emergency plan, and bring it with you. Okay, next slide, please, Melanie. So when do you call 911? All right, so you've utilized crisis response, you've done whatever you can in order to contain the situation, and it's still not working. Your relative acts unsafely towards himself, herself, or others. All right, so now is the time to think about the possibility of getting the person to a screening center and being evaluated. Please do not attempt to transport your family member to the local hospital emergency room yourself. I cannot tell you how many times family members have been injured in the process of trying to transport their relative to the emergency room. Arrange for somebody to take over the care of your other children, other family members for whom you're responsible, pets, so that you are available to follow the rescue, so that there'll be somebody that comes when you call 911. The police will most likely escort your relative to the local emergency room. You can follow the police vehicle to the emergency room and meet your relative at the emergency room, but please do not transport them there. Gather information like the portable emergency plan, your legal guardianship papers, and clothing for your relative. Gather anything else that you think would be necessary to keep your relative calm and engaged. You may have to wait quite some time in the emergency room. So, and if you have a relative who is a frequent visitor to the emergency room, you may even want to have a suitcase all ready to go so that you have everything pulled together in advance of such an event. Okay, Melanie. So what can you expect? You've called 911. and your relative is transported to the local emergency room. So in some hospitals, the medical emergency department and the psychiatric screening are co-located in the same site. In other hospitals, they're in different locations. The first personnel that will see your relative are the medical staff, because the person must be, your relative must be medically cleared in order to go to pass on to the screener. So a blood test and other tests may be ordered. X-ray may be ordered if the thought is that maybe your relative broke a bone or something. And then there'll be a determination if there's any medical reason for your relatives presenting problems. And if it is not the case that there is your relative does not have a raging infection, all vital signs and blood work are within reasonable normal limits, then it may be determined that a psychiatric screener will next see your relative. And again, that may mean transporting your relative to another site. It may be that the psychiatric screener comes from another location onto the medical emergency room site, but it's going to be a switch of personnel from the medical personnel to the psychiatric screener. These are people who are trained as psychiatric screeners. They need to be certified. While you're a relative in the emergency room, they may be given a PRN. A PRN is medication that's given as needed. If your relative is in need of being calmed down, they may give some medication. If for some reason your relative has a history of adverse response to medication, make sure they know about this so they're not going to unknowingly give your relative medication to which they may adversely respond. And they may actually restrain your relative. So if your relative is acting unsafely towards him or herself or others, it may be necessary to put the person, your relative, in restraints to calm them down. But if your relative is calmed down and you notice that, you can ask that the restraints be removed. And again, this is determined by the hospital personnel, okay, but you can ask that. Adults can be seen in the ER by a SCAT clinician. So if the SCAT clinician has not seen your relative prior to their entrance to the emergency room, that may be the first visit. Or if the person has been seen, they may get a follow-up visit while the individual is in the emergency room. Again, you may be waiting a long time, so bring things with you for your relative to look at, keep them occupied, etc., especially in some of the busier emergency rooms where there's a lot of activity. It may take quite some time before the screener or psychiatrist gets to see your relative. Next slide, please, Melanie. So if your relative needs to be hospitalized, it's important for you to know there's several levels of hospitalization. There is what's called a voluntary unit, and there is what's called involuntary commitment or a short-term care facility unit. If your relative is his or her own guardian, legal guardian, or if you are a relative who's a guardian and you're in agreement that the person will benefit from a psychiatric hospitalization, they may be able to go on to a voluntary unit. That is a less restrictive unit than a short-term care facility unit. If your relative needs a higher level of care than is available on a voluntary admission, they may either be committed to the specialized Trinitas unit, 2D, if they're 18 or older, or they may be sent to a short-term care facility unit in a local hospital. That is an inpatient unit that is dedicated to the acute care of individuals who are in crisis, in a mental health crisis. Children under the age of 18 can be screened for hospitalization, but we do not commit them they are not put through commitment process as are adults. If they need hospitalization, they may be placed on one of the CCISs. There are 9 CCISs. Those are inpatient services for children that are dedicated crisis children's inpatient services. There is a specialized, there are 10 specialized beds at Trinitas on the child and adolescent unit. So that may be one place, or they may be put into a local, one of the other CCISs throughout the state, depending on availability of beds. Next slide, please, Melanie. So the family, I know family members often complain to me that they're not taken as credible sources of information, and when they go to the emergency room, the process just kind of takes on a life of its own, and people do not pay attention to what the family has to say. So I've got to tell you that the family is the most important source of information about the individual who resides at home. So don't accept workers who dismiss your input, no matter what that worker's position may be in the emergency room. You're the one who knows your relative. You know what contributed to the crisis. You know what would be likely to help your relative calm down. You have valuable information to share about routines, medical history, response to medication, and approaches that have or have not previously worked. All that is important. And be prepared to share that, because the emergency room staff and the hospital unit staff do not know this information about your relative. You are the ones who own that information. Next, please, Melanie. So hospitalization on a short-term care unit, whether it's the specialized unit at Trinitas or any short-term care facility unit throughout the state, the purpose of it is for acute care and treatment of people who have a psychiatric illness. So it is meant to be a short-term stay. This is not a residential setting, okay? So the average stay on a short-term care unit is from 7 to 10 days. It's about 12 days at this point in time. If you have objection to psychoactive medications being used in the treatment of your relative, then they do not belong on an inpatient unit, because that is the main way in which treatment proceeds. It proceeds pharmacologically. Don't expect your relative to be placed residentially from a hospitalization. That's not a purpose of a hospital stay, and hospitals do not have access to residential placements for individuals with intellectual and developmental disability. That is not something that the typical short-term care facility unit has any resources or access. While on any inpatient psych unit, please remain in contact with the social worker or discharge planner and request to speak to the attending psychiatrist while your relative is on the unit. If your relative is on the 2D unit, you'll be invited to a discharge planning meeting, and that would be a good opportunity for you either in person to go onto the unit or by phone participate in discharge planning for your relative. Thank you, Melanie. So what do you do after the crisis is over? So one of the things about crisis response is our job is to try to prevent crises from occurring. And if we're not successful in preventing them from occurring, we're looking to prevent them from reoccurring. If your relative is linked with the Division of Developmental Disabilities, ask for an emergency IDT involving your relative's case manager or support coordinator and all members of the multidisciplinary or interdisciplinary team. Suggest that the crisis situation is an opportunity to reevaluate your relative's behavior plan, if they have any, medication regimen, and current supports in light of the recent crisis. If there's been any gaps in services that have been identified that led to the crisis situation, advocate for additional resources and involve the IDT in exploring the therapeutic options and resources that are available. Follow up with SCAT, we'll put again the toll-free number, or the Rowan Crisis Team. The Rowan Crisis Team follows up with people in Burlington, Cumberland, Gloucester, and Salem counties. SCAT responds to crises in the emergency room throughout the state, even in those counties, and we respond to emergencies in the community except for those 4 counties where it's the Rowan team that has responsibility for response. Follow instructions regarding prescribed medications. Contact your relative's treating practitioner if you have questions or concerns. Very often, if your relative is started on new medication, they may be very groggy and sedated as a result of the new medication. Don't be surprised. Ask the practitioner about it. What can you expect in terms of the efficacy or seeing a change based on the medication? Next slide, please, Melanie. So, helpful responses to crisis. We need to replace, and by that I mean all of us involved in crisis response, our current reactive and cyclical approach to crises with an approach that's more effective in reducing the likelihood of future emergencies and result in better outcomes. An appropriate response to crises involves keeping the person physically and psychologically safe, fully understanding the circumstances that are most likely to contribute to behavioral or mental health emergency so we can control for dangerousness and engage in watchful waiting way before any crisis situation occurs. Consider developing an advanced mental health directive. So if you know that there's certain hospitals that you've not had a good experience with your relative, if you know there's certain techniques that have been used that have not been particularly efficacious, if you know there's certain medications that have been problematic, that can all be put into an advanced mental health directive that will give professional caregivers more guidance in future situations. Okay, Melanie, take it away. So again, I go back to this issue of safety because actually that's how we define crises. It is when there is a disturbance or when people are dangerous to the point of being physically or psychologically unsafe. So what we need to do is we have to figure out what's necessary for your relative and for you to feel safe. What resources can be pulled in to regain personal and family equilibrium? So safety is both a psychological and a physical experience. So begin to think about your support networks, both formal and informal, and how you can begin pulling in resources to help you, your relative who had been in crisis, and the other family members. Okay, Melanie, next one. Okay, so services should be provided in the least restrictive manner. Maintain contact with usual formal and natural supports. Please, this is not the time to isolate unnecessarily from family members and your extended family, from your faith-based group, from professionals, from friends who may be of assistance through the crisis event and beyond. So for instance, maybe you have neighbors who are willing to help you in some way, even if it is transporting your other children or providing care for other members of the family, not the individual who's in crisis. Maybe your faith-based group can be helpful to you. This is a time to look at both your informal and formal supports. Look into county-based resources such as your county mental health association. Every county has a mental health association, and very often they have resources that can be helpful to you. They maintain a directory of local resources that are county specific. Next one, Melanie. I put on your slides some peer supports. So Mom to Mom, which is one of my favorites, and that is their toll-free number. These are for the most part women. I think everyone, since it's Mom to Mom, who have had to get through crises of their own family member and have been trained to how to be helpful as peer counselors and supports to other mothers. It's not that we think fathers are not sometimes affected by this, but this is dedicated mom to mom. We just have to do a dad to dad. So if anybody wants to in the audience be involved in that, let me know. Okay. And then the local mental health associations have what's called intensive family support services. So that is somebody who comes out and works with the family, not the person who was in crisis only, but the family members, to give the family support in order to better support the person who was in crisis. And of course, NAMI, the National Association for Mentally Ill, run peer support groups and many resources. And I put their New Brunswick, I think it's a New Brunswick number on your slide. So what will you do after the crisis? Well, I think one of the things to look into, go online and look at Wellness Recovery Action Plan. This is something that the Division of Mental Health and Addiction Services, works with our population of individuals with mental health disorders, but we are trying to bring that into our thinking for people with intellectual and developmental disabilities. And it's actually kind of a mental health and behavioral health IHP, if you will. But it's a toolkit. It's a way for the family to think about what resources can be put in place to help. Evaluate the recent crisis to identify what may need to be changed in a family crisis plan. If you don't have a family crisis plan, develop a family crisis plan. What will every member of the family do in the event that your relative, again, has a behavioral health or mental health emergency? And what types of longer-term supports and services do you need to reduce the likelihood of another crisis? Recurrent crises usually signal there's been some failure to address an underlying issue, either not addressed sufficiently or not addressed at all. And we may need to work with local law enforcement or screening centers. SCAT does training throughout the state with law enforcement. We tell them, don't put your sirens on, don't take the handcuffs out. We work on ways of approaching the individual if the police need to be, or first responders have to be pulled in to respond to a situation. And so, you may need to give your local police department a heads up about your relative and have a conversation with a local officer. Each precinct has a liaison, a community liaison officer. Okay. Okay, so the family needs to regroup following a crisis. You may need to take some time off from work or your other responsibilities in order to establish your own equilibrium and the equilibrium of your household. How can you care for yourself, and how can all members of the family support their own well-being during a crisis? That means making sure everyone's getting the sleep they need, they're following the nutrition they need to follow, getting exercise, all the things we would do to maintain health, maintaining social connectedness, and trying to keep routines to the extent possible. Determine if you need to increase direct or indirect supports to you, your relative, or any other member of your family. Maybe you need to get somebody in to help you with domestic chores, Maybe you need to get somebody in to help you with transporting people. Maybe you need a new behavior support plan for your relatives, and maybe another member of the family. Maybe people need counseling. Make sure all the members of the family have been supported throughout the crisis. You may notice that individuals such as siblings of the individual who is in crisis may show changes in their grades at school or their work performance, and they may be suffering their own kind of sequelae or aftermath of their relative being in crisis, and you may be as well. People may become anxious or depressed in the aftermath of their relative's crisis situation. Everybody needs attention, not just the person who had been supposedly in crisis. Okay, Melanie, next one. Oh, we're perfect timing. Okay, so now I would like to invite people if they have any questions and if there's any way that I can be helpful. That's my name, and that is how you can get in touch with me. That's my Trinitas email address.
Dr. Ezra Liu, thank you so much, as always, for all the valuable information that you were able to share with our families today. We do have a few questions. The first question comes from a family member, and it says it can be difficult for caregivers to find psychiatrists for this population. Is there a directories that family can access?
Yeah, well, that's a great question. We've been struggling with that for years, about identifying people who are specialists in the area of prescribing psychoactive medications. What I would say is that our best bet is to go through, I mean, there are certain people who have, established expertise. And if you're interested, you can call the SCAT number and we will pull up what we have in our directory depending on your region, and we'll give you some suggestion. The other possibility is to go through the managed care organization that your relative may be connected to and ask the healthcare administrator manager who's assigned to your relative's care through the insurance as a subscriber to identify people in the network with some known expertise. We've been trying to work with the managed care entities as well to identify people in each region who have. Now, some people do not have working with a population as a specialty, but they include working with people with IDD as part of their general practice and have been effective and successful in doing that. So the answer is, please feel free in giving us a call at the 888-393-3007 number, and or you can contact me via my email, and I will get information that we've been trying to keep track of people who identify themselves as having this area of specialization.
Wonderful, thank you. One of your slides referenced an emergency IDT. Can you explain what this is?
An IDT is an interdisciplinary team meeting, so that if somebody is linked to DDD, traditionally, in addition to the IHP, there has been what we call an IDT, an interdisciplinary team meeting, in which all people involved as stakeholders in support of the consumer are gathered to discuss a situation. Whenever there's been a change in the level of care or in the level of functioning, that should be a trigger event for calling that kind of team meeting.
Again, thank you. We have actually, someone has asked for the contact for NAMI. I will actually, Dr. Ezra, if you're comfortable, I'm going to send a copy of your PowerPoint to everyone, if that's okay with you.
Good.
Perfect. So
absolutely.
So if anyone missed any of the contact numbers referenced during today's presentation, I'm going to send you a copy of the PowerPoint as a PDF file, and that way you can reference the slides at your convenience. So we have a family member who is wondering if there are supports available to siblings who have experienced crisis within the home.
That is an excellent question. To be honest with you, I'm only aware of one practitioner down in Southern Region who has run a sibling support group for individuals with intellectual and developmental disability. If this family member would be interested, or anyone in the audience would be interested in contacting me, my go-to person for information for the state of New Jersey is Bev Roberts from the ARC of New Jersey. So I'll pick her brain, and I will also go through some of my contacts in the regional offices of DDD to ask if there have been any other practitioners or groups that have identified themselves as providing support to siblings.
Wonderful. And how about the IFSS that you referenced before? Would they provide any support? Or is that for general family?
And actually that's an excellent point. They may have access to that type of information. So every county, through its mental health county association, mental health association in each county, I should say, and there are 21 counties in New Jersey, has access to IFSS supports. That's intensive family support services. And they may very well know if there's anything locally for siblings within the county.
Wonderful. And the Family Support Center of New Jersey does offer, again, I do want to get more information from this family member, but the Family Support Center of New Jersey does offer a sib shop, and it is a sibling support group. It's not a therapy session, but it's a great way for siblings who have a sibling with a developmental disability or any disability to come together one time a month with another group of kids from their area. It's very light, airy. The conversation is sort of free-flowing, and the kids approach the topics as they're comfortable. And there's a lot of activities that work around the topics for the kids to share some of their experiences. And it really allows children who can sort of understand and relate to some of the experiences that the other kids may be going through. Again, different avenue, not therapy-based, but it's still a support that may be helpful. So absolutely, we'll get more information from that family to make sure that that we're providing some additional guidance. And
yeah, Melanie, as it occurs to me, I would throw out the offer to the participants in today's webinar that if they are interested in looking at potential support services for siblings, I'm looking at one of my staff as I'm making this offer, that maybe you can think through if there's some way that SCAT could be helpful with regards to that. No? I mean, is that
wonderful?
I'm looking at two of my staff with regard to that. Yeah.
Perfect. So one of the last questions that has come in is really asking about medications. This family member feels like the person who had experienced some crisis was on so many medications that it possibly could have been some of the medications interacting with each other to trigger some of these behaviors, and was worried about the person just being put on more medications because of the behaviors. How does someone determine if it's a medication causing crisis or not?
Well, and again, this is working closely with the prescribing practitioner. So it's reasonable to question what value a very extensive medication regimen has, and what is actually contributing to any help, and what may not either be adding any value or actually may be complicating the situation. So if this family is not working with a practitioner who is willing to investigate that, then it may be time for a consultation with another prescribing practitioner, whether that be a psychiatrist or primary care, etc. So it's a reasonable question, but the only way to find out is by doing it along with and in collaboration with a physician or somebody who is able to prescribe medication and look about peeling certain things back. Look, so what they'll often do is they will take a medication and eliminate one at a time. They'll reduce the dosing and take it off and see if there's any change in the behavior. So, and sometimes there are reasons not to do that, and it may have to do with a concern about how that might destabilize the individual, and unless they were in a medical setting like a medical unit where that could be safely done and monitored, they might not, the practitioner might be unwilling to do it. But the way to do it is to either speak with the current practitioner and or get a consultation with another practitioner.
Dr. Esliver, again, I do want to thank you for all the time and dedication that you've given to this subject. On behalf of the Family Support Center of New Jersey, we thank you again for joining us today. We hope that you join us for our future webinars. You can find a list of those future webinars on our website, which is fscnj.org. We try to hold them around lunchtime to have for the convenience of everyone who works. And we do offer some evening sessions. We actually have a sibling session coming up, I believe, next week in the evening, which would be great participation for any of the siblings out there and families as a whole. So again, Dr. Esler, we thank you very much, and we hope to speak to you soon. Thank you again, everyone. Have a great day.